Thank you very much. It's a great pleasure to be here. It's my first VNMS meeting. So I'm the Chair of Clinical Oncology here in Glasgow. I'm a radiation oncologist. I treat patients with brain tumours. I also run a lab trying to look at ways to make radiotherapy more effective in the treatment of brain tumours and some clinical trials testing that in patients. And I'll cover or touch on all of this over the next 15 or so minutes. And I was really pleased to be invited to talk at this session because there is a huge need for better imaging of brain tumours, in particular response to therapy. So I'm going to ask 3 questions really, and then hope that the next 2 speakers will answer them. Some disclosures. Okay, so my first question was one that I think many people think of as being perhaps a key role for imaging, which is to give better or more precise diagnosis and maybe even tell us about the molecular status of tumours in order to help us diagnose, classify and manage them better. And obviously MRI is our standard treatment. It's pretty useful, gives us a lot of anatomical detail, but we can see a really quite diverse range of appearances in tumours or probable tumours in the brain. And obviously we have to determine whether they're primary or secondary, and if they're primary, then we need to know what grade they are, what their histology is, and all of this guides prognosis and treatment. And so obviously it'd be great if we could do that non-invasively and spare some of these patients from having brain surgery, which is obviously not a small thing. But in thinking about this question, really, I think the way we view this question has changed quite dramatically in the last few years because of the way that primary brain tumours are now classified. So in 2021, the WHO updated its classification of brain tumours, and the main change really was the increased use of molecular assays to actually determine diagnosis and in some cases grade. And so obviously our main primary brain tumours are the gliomas, and really we can't diagnose and classify a brain tumour now without certain molecular tests. And this is a change because it used to be the histology that guided the diagnosis, and then the molecular data was just a bit of added extra. So you can see here that astrocytomas have to be IDH mutant, oligodendrogliomas have to be IDH mutant and have a 1p19q co-deletion, and glioblastoma now have to be IDH wild type. So those are requirements for diagnosis. In addition to those, we've got a lot of other molecular markers that are not yet used for diagnosis, but do give additional information about prognosis, and not yet, but hopefully in time, will help to guide treatment as well. So you probably know this, but just a quick background on the main molecular markers. So 1p19q chromosomal deletions are absolutely diagnostic of oligodendrogliomas, and that can be determined either using FISH, so fluorescent in situ hybridization, using probes for those 2 chromosomal regions, or, and more commonly nowadays done looking at gene copy number, often by array CGH. So both of those assays obviously require tissue. The IDH mutations, a really interesting, fairly recent discovery, which was that the majority of lower grade gliomas are driven by mutations in either IDH1 or IDH2. So these are 2 components of the TCA cycle. And the impact of those mutations is to shift the metabolic pathways within that cycle, so that we get very high levels of this oncometabolite 2-hydroxyglutarate. So the mutant form of IDH1 or IDH2 will shift the balance towards production of this molecule. And 2-hydroxyglutarate is called an oncometabolite because it blocks the activity of other enzymes that would normally be modulated by the other molecule within the chain that is no longer synthesized, which is alpha-ketoglutarate. And if you look at the dioxygenases that are modified by alpha-ketoglutarate, you can see that there are actually hundreds of them. And this is why IDH is now known to be the driver mutation. So the product of the mutant form is then indirectly influencing the activity of this huge family of enzymes, which then leads to a malignant phenotype. So we can test for IDH mutations in two different ways. We were lucky that there's a really nice antibody to the most common mutated form of the protein, which is the R132H mutation of IDH1. And if we don't see that on immunohistochemistry, then the patient samples will be sent off for sequencing of both the IDH1 and IDH2 genes. And this is now done routinely and is required for diagnosis. And the reason that the classification was changed is because these mutations or codeletions have a massive impact on prognosis. So here we're looking at low-grade glioma patients who required treatment. This is regardless of what treatment they received in the trial. And you can see if they had both the IDH mutation and the 1p19q codeletion, they had fantastic overall survival, with the vast majority of patients still alive at 10 years. If they had the IDH mutation but not the codeletion, then they had an intermediate prognosis, and if they were IDH wild type, then they had a very poor prognosis. And that survival curve looks a bit more like a glioblastoma, even though histologically these tumors had been determined to be low grade. So these immense differences in survival is what has driven the incorporation of these molecular tests into our diagnostic process. And if we look at higher grade gliomas, glioblastoma on the left and anaplastic astrocytoma on the right, you see again that the IDH status has a massive impact. And for glioblastoma, what this means is that we can't call a tumor a GBM if it has an IDH mutation anymore. That would now be a grade 4 astrocytoma. The other molecule we're very interested in gliomas is MGMT, which can be silenced by promoter methylation. And if that gene is silenced by promoter methylation, then the patients have a better prognosis. So in this graph, the blue, dark blue and red curves are the unmethylated tumors, which have a very poor prognosis. And the other two are methylated. They have a better prognosis overall, and they do even better if they're treated with temozolomide. So this is both a prognostic and a predictive biomarker. So taking all this into account and the absolute requirement for that molecular information, my personal view is that it's not really going to be possible to diagnose and classify primary brain tumors non-invasively. And the other thing is that actually we've got increasing evidence that surgical debulking improves outcomes, even for patients with low-grade glioma now. So it's much less common now just to observe low-grade glioma patients. So taking all of that into account, and being perhaps slightly controversial, I think that for this question, with imaging, we're unlikely to change practice. And that's because we need multiple molecular biomarkers, and because the vast majority of these patients are going to have surgery anyway. I'd be very happy to be challenged on that question. Okay, the next question is whether we can distinguish between tumor progression and what we call pseudoprogression, which is closely related to treatment effects, particularly following radiotherapy. And I'm sure you're all familiar with this, so I'll just show a couple of images. Here we have a patient with a GBM. They are MGMT methylated, so we think they're going to be more responsive to radiation and temozolomide. And here we have the pre-op MRI on the left, then the immediate post-op scan, and then in the middle we have this scan 1 month after completion of 6 weeks of chemoradiotherapy. And you can see that there's this new cystic area which has got a contrast-enhancing rim, and there's additional new contrast enhancement in the tumor bed. And we look at that and we are kind of familiar with it. No, that's probably pseudoprogression, especially as you can see that the next 2 scans show a very gradual resolution of those changes without additional treatment. But if you're in clinic seeing a patient who's just got through this really arduous treatment and they show up and this is their scan, it's a really difficult conversation because the 2 potential outcomes are polarly opposite. So the good outcome is that this is pseudoprogression, and that means you're probably going to do better, and we expect that your tumor will eventually be controlled and you may be off treatment for quite a long period of time. The other option is that this is your tumor growing despite this intensive therapy, and if that's the case, then your prognosis is extremely bleak. So that's the first thing we have to present to these patients, who obviously find that very difficult to take on. And then the second question is, are we going to change our treatment? If this is genuine tumor progression, then we need to offer them second-line treatment. But if it's not tumor progression, we would be subjecting them to very toxic, unpleasant treatment unnecessarily, and we also reduce our ability to give them subsequent therapies later on if they do genuinely have tumor recurrence or progression. So I can't overstate how difficult this is to manage and how helpful it would be to have a definitive imaging test for whether it's progression or pseudoprogression. And just showing the FLAIR images, you can see these are even more dramatic. So looking at that 1-month post-chemoradiotherapy scan, we've got this massive T2 FLAIR changes around in our treatment volume and around it, which make that decision even more difficult. It's important to notice also that pseudoprogression can persist for several months. People think that it's probably the first scan that would show that, but actually it can persist for several months. And sometimes it even gets worse after the first scan, so that you'd probably do another scan 2 months later, and you might see even more enhancement and more edema, and that could still be pseudoprogression. So that's the basic problem there. It gets even more complicated, though, because the likelihood of seeing pseudoprogression is related to how effective your initial treatment has been. So the more effective your treatment, the more likely you are to see pseudoprogression. So that adds to the clinical conundrum. We also have emerging data that although immunotherapy in general hasn't improved outcomes for GBM patients, some patients who do respond to it, they have a really marked pseudoprogression change on their imaging. But this issue makes it extremely problematic in the context of a clinical trial, because if your new treatment is genuinely more effective than standard of care, you're probably going to see more of this pseudoprogression in the imaging. And what this means is that we cannot really use progression-free survival in GBM studies. And pharma companies hate that because they want a quick readout. So we say, no, if you use that, it's probably going to give you a misleading answer. And so we have to use overall survival, which then extends the duration of our trials. So I'm just going to give you a quick example of a trial that I've been running, which is using ATM inhibitors. And so ATM is a key protein in the DNA damage response. It activates the G2M checkpoint and also promotes DNA double-strand break repair. And if we inhibit ATM, we get a very significant radiosensitization. And in that plot, it's the red curve at the bottom, which is clearly a larger effect than any of the other DNA repair inhibitors. And we see that in vivo as well as in vitro. So we developed with AstraZeneca a brain-penetrant ATM inhibitor, which we tested in combination with radiotherapy in recurrent GBM and newly diagnosed GBM. And I'm just going to show you the results from the recurrent GBM patients. And so here we've got a swimmer plot which essentially shows duration of time since starting treatment. And you can see that some of the patients are living over 2 years in this study. But the little symbols tell you what the imaging showed. And the red symbols are progressive disease by Rano criteria. So you can see that out of the top 6 best survivors, 4 of them were diagnosed with progressive disease at the first scan after treatment. And some of them had multiple scans showing progressive disease. And those patients then went on with no additional treatment to live for over 2 years, which for recurrent GBM is very, very unusual. So for this study, the median event-free survival was calculated at 4 months, which is rubbish. But actually the median overall survival was 12.7 months, which is actually very good for recurrent GBM. So this, I hope, really illustrates that point. And if we had an imaging method that could confidently tell us if something was treatment effect, not progression, then that would completely change our progression-free survival data. So that's sort of immediate changes post-treatment. We're also concerned about late changes after treatment. And we see this for both primary brain tumors, but also for secondary. So we often use stereotactic radiosurgery for brain metastases. And these images show a patient 1 year after SRS treatment for a brain met that was situated here. And you can see that the imaging at 12 months would be entirely consistent with a recurrence of that metastasis, but also potentially with radionecrosis. And here we've got a methionine PET, which would very confidently point us towards treatment effect, because we're not seeing an increase in uptake in that area. But as yet, nothing has really been clearly defined and validated. Here's a recent study that I found, which was using fluciclovine PET to try and distinguish progression from pseudoprogression. And what I think is important about this study is that it also acknowledges the complexity of diagnosing pseudoprogression versus progression, even when you have tissue. So in this case, we've got a patient with MRI changes which are suggestive of tumor recurrence, and the fluciclovine PET would be very in keeping with that, whereas the MRI was not, would have failed to detect that. And when that was biopsied, the histology showed a mixture of 60% tumor and 40% treatment effect. So this raises a whole other problem. We're not just dealing with black and white, pseudoprogression or progression. We've got patients that have got a mixture. In this study, they were quite confident in saying that the fluciclovine would separate out the pseudoprogression patients from those who had a mixture or had pure tumor progression. And these are sort of corresponding images for true progression on the left, mixed in the middle, and pseudoprogression on the right. So that's, sort of the figures are quite helpful, but the imaging, I'm not sure whether a clinician would be convinced by the scan on the right as being pseudoprogression, because it's red, right? There's a red blob, but that surely means there's active tumor there. So I think we've made some progress, or you guys have made some progress in this question of distinguishing between progression and pseudoprogression. But I think there's more work to do, and if you could do it, it would be incredibly helpful for all of us, all of our patients, and for clinical trials. My final question is about measuring neuroinflammation. And this is relevant to tumor biology, but I'm going to focus more on the issue of the side effects of our treatment. So radiotherapy is a key part of our treatment for brain tumors, and it is effective, but it does cause severe problems. So over half of our patients will develop irreversible cognitive dysfunction after their treatment. And this is a patient we had. It's a rather extreme example, but she had a tumor that was well debulked. She had localized chemoradiation, did very well from the tumor perspective, but 18 months later, you can see she's got global cerebral atrophy and had dementia. We kind of expect to see radiation changes in the treatment volume, but I think it's really important to recognize that these effects of radiation are seen throughout the brain. And this has actually now been quantified through MRI, volumetric studies, which have shown dose-dependent, but also dose-independent reduction in brain volume in all the relevant substructures in the months after radiotherapy. And while we're still learning about how radiotherapy damages the brain, what we do know is that many of the understood mechanisms are localized, whereas one that could potentially explain these global changes is radiation-induced neuroinflammation. And this is driven, we think, by microglia, which are immune cells in the brain, which are activated by radiation to create a persistent state of neuroinflammation. So if we could measure neuroinflammation, either locally and in a generalized fashion, prior to treatment, we could potentially identify patients who were at higher risk of neurotoxicity, and during and after treatment, we could maybe detect our radiation-induced changes, correlate them with neurocognitive outcomes, and then perhaps investigate drugs to alleviate those problems. And returning quickly to our ATM inhibitor, what we've been quite excited to see is that in mice, if we give this ATM inhibitor with the radiation, we can actually significantly reduce neurocognitive decline. So if we measure a mouse's nest-building ability after radiation, which is the black line, we see this quite marked drop, which persists out to 6 months. But if we give them the ATM inhibitor with the radiation, we can significantly reduce that. And the same effect is seen with a more sophisticated novel object recognition test. We think the mechanism involves microglia, because this blue box is showing that that combination of radiation and the ATM inhibitor depletes microglial cells, and perhaps that's why there's less neuroinflammation. So I think this is an exciting new field, and I think the ability to measure neuroinflammation would be really interesting for scientists and clinicians, but importantly would give us a tool to help us test new ways of ameliorating radiation-related neurotoxicity. So I'll finish there with my 3 questions. The first one about diagnosis and classification. I'm very skeptical that there's an important role for nuclear medicine. For the second question, I'm very excited and think there's a massive opportunity. And the third question, I think it would be really interesting to get a bit more, get some more tools to look at that question. So thanks again for the opportunity to speak, and I'm looking forward to hearing what the other speakers have to say.